Hi, my name is Albie and I'm the attending physician. The case report is Lazarus phenomenon. A 98-year-old Caucasian woman, body mass index BMI 17.2, with a known medical history of hypertension, rate control atrial fibrillation, hypothyroidism, aortic insufficiency, lymphedema, and hypoxia secondary to partial lung resection, on home medications of warfarin, levothyroxine, metoprolol, montelukast, furosemide, ipratropium bromide, and fluticasone presented to nurture LIJ Plainsview Emergency Department at 2:30 p.m. after a witness fall not associated with head trauma or loss of consciousness. Her vital signs and presentations were blood pressure of 144 per 81 millimeters hectogram, pulse of 119 beats per minute, respiratory rate of 18 breaths per minute, temperature of 98 degrees Fahrenheit, and oxygen saturation of 85% on room air. Our patient's baseline oxygen saturation was unknown, and she denied being on home oxygen therapy. On physical examination, our patient was not wheezing on presentation but revealed shortness of breath on room air with diffusely scattered bronchi. An electrocardiogram ECG revealed atrial fibrillation at 113 beats per minute, along with right bundle branch and left anterior vesicular block. At 3:30 a.m., our patient suddenly became bradycardic and progressed to asystole. She was found to be pale and pulseless. Cardiopulmonary resuscitation (CPR) was immediately begun following an advanced cardiac life support (ACLS) protocol. Initial respiratory support with a bag mask was attained, and our patient's trachea was secured with intubation at 3:32 a.m. As per the ACLS protocol, 1 milligram of intravenous epinephrine was given, followed by 40 milligrams of intravenous vasopressin given at 3:36 a.m. Our patient received her second dose of 1 milligram epinephrine at 3:40 a.m. Finally, at 3:46 a.m., our patient received 1 ampule of sodium bicarbonate. Our patient remained unresponsive to continued resuscitation efforts, so CPR was abandoned at 3:48 a.m. Right femoral venous access had been attempted during the resuscitative efforts, and cardiac monitors were unwittingly left on our patient during cleaning and removal. At 3:51, before the complete removal of the femoral venous catheter, a single ventricular contraction was noticed on the monitor. The single contraction progressed to a couplet, then a triplet, and finally into a normal sinus rhythm with a palpable pause at 3:53 a.m. Her initial blood pressure was measured at 80/50 per milliliter hectogram, and our patient was started on a norepinephrine drip at 10 micromilligrams per minute through the femoral venous axis. A right femoral atrial line was also established for continuous blood pressure monitoring. Her blood pressure stabilized at a mean atrial pressure of 70, and our patient was transferred to our intensive care unit ICU at 4:30 a.m. In the ICU, a hypothermia protocol was initiated, and vasopressors were titrated to maintain systolic blood pressure greater than 90 millimeters per hectogram. Unfortunately, at 10:55 a.m., our patient went into ventricular tachycardia, and despite resuscitative efforts, our patient was pronounced dead at 11:03 a.m.